everyone. Welcome back to our series on the Prehospital Pediatric Readiness Project. We are now in the 7th and final section of this checklist. We hope that some background and discussion about why these elements were part of the checklist, as well as some examples of either ways to know that you're doing it or directions to try and meet those objectives have been helpful. We are going to end, I think, on a big picture item, which is the interaction of the EMS agency or system with the rest of the healthcare system. So the first bullet in this is that there's policies, procedures, protocols, and performance improvement initiatives that involve ongoing collaboration with pediatric emergency care, public health, and family advocates. That is like really big. So give me an example of like, what does that look like? How would I know that I have a policy, procedure, or protocol that demonstrates ongoing collaboration with public health or pediatric emergency care?
Yeah, so something we developed through our county child death review committee. One of the things, obviously, you review are infant deaths and those related to unsafe sleeping. So we collaborated with them and Cribs for Kids to develop a program to try to like interdict these cases. Because once you get to the sudden infant deaths, usually there's just no chance to save these kids. So what we do now to try to address unsafe sleep, when we go on a call for an infant and it's something relatively minor in the home, we ask, hey, can we see where the baby sleeps? And we call it a 30-second safe sleep screening, which is the best practices out of the latest American Academy of Pediatrics paper on infant sleep. So we'll do a quick screening. It's like a checklist with like 6 or 7 items. And if there's any unsafe actions that we see, we leave some literature behind. And the biggest thing we do is if there's no crib in the house, through Cribs for Kids, we'll get a crib delivered to the house within 24 hours. So that's something that came out of a collaboration with the health department and public health.
That is a really great example of how to collaborate. So the next like sub-bullet of this bigger section is that you have plans and exercises for disasters or mass casualty incidents, and which I think a lot of systems have, but specifically thinking about preparedness to take care of children during disasters or mass casualty incidents. So it has things like the care of pediatric patients, so disaster triage and mass transport, and how do you dose an antidote, right, for a child? How do you track unaccompanied children? How do you put families back together? So
the good news is that we now have an excellent national resource in the way of the Pediatric Pandemic Network, led by Dr. Charles Macias and Dr. Joelle Simpson, experts in the field of public health and disaster preparedness. You can find information regarding pediatric specific care and disasters and mass casualties through the pediatricpandemicnetwork.org. Similar to what we were talking about with PPRP, this particular website provides the resources, numerous resources that you need or may need to know to prepare for your local jurisdiction, and to kind of, accommodate that to where you are. I think the other thing is, again, like everything that we've said before and everything that we do within EMS systems, just like certain populations, we should integrate pediatric specific protocols and plans when it comes to disaster preparedness. That should be a forethought and not an afterthought. So when we were having these disaster medicine table exercises and things of that nature, we should always integrate a pediatric specific example for our EMS clinicians and EMS leaders to be aware of. Again, like we talked about previously in other modules, also being aware of what your community resources are in the way of public health, in the way of your community pediatric experts and where they are, and to know your healthcare systems within your community and what their pediatric specific resources are.
I think that just covered the rest of it, which is perfect. So we have gone through each component of this checklist. And I think it's time to sort of bring it all the way back. I think we started, with education, and we went to resources, and then kept going until we ended sort of like big picture, how are we integrated into the overall system, with the idea that how you're integrating with the overall system really is part of the system design of whether or not you're prepared to take care of children, whether or not that's an individual pediatric call for respiratory distress, or whether or not it's a mass casualty event, right? Like of a school bus getting hit or something like that. So I anticipate, as I'm going through my head about our own readiness, that people are going to go through this assessment and they're going to check a few boxes off and say, that feels really great. And then they're going to look at some of these things and be like, oh, like we probably have some work to do. What do you think are the next steps, after somebody goes through these assessments? What should they do with that information? How should they prioritize what they find?
I would say don't get overwhelmed. I mean, don't go through the checklist and, oh my God, I got all these boxes not checked. That's completely fine. The goal is do something that's going to make your system better, and pick maybe 2 or 3 items that you're interested in or you want to prioritize, and just fix those 2 or 3 items over 6 months or a year, and then move on to the next or 2, 3. So, don't get overwhelmed and I got to fix 20 pieces at once. No one can do that. Just take it in bites. And then when you see this good system improvement and people buy in, then you take the next bite.
I agree. I think Chief said it best. Also remembering that this is a baseline for us. This is the first time we're doing an assessment to this magnitude. This is more of, collecting data and finding out where we are currently. So this shouldn't be kind of a pressurized assessment in that you need to do it or you don't meet qualifications. It's more of to get a feel of where we are now and where we need to go. And so the steps you want to take over the next couple of months is to work with your agencies to go over the checklist and just kind of see where you are. And if you find deficiencies or areas where you need to improve, guess what? Step number 2 is to go and look at the toolkit, where there are numerous resources to kind of help you to clue into where you may be able to fill in these deficits. But to Chief Pinchalk's point, not overwhelming yourself and saying every single box they need to check off in every single subject matter. Pick a few things, that low-hanging fruit that you think will be feasible for your EMS agency and doable. I will say one thing about the systems of care that we found with the National Pediatric Readiness Project. Now, the National Pediatric Readiness Project is looking at emergency departments and their pediatric readiness. And what we found is one of the most important things to have is somebody who has an expertise in pediatric medicine. And what I want to emphasize is it doesn't have to be a doctor, a physician. It doesn't have to be, like I said, a triple boarded pediatric physician. It could be an EMS clinician. It could be a nurse. It could be a tech. And so that might be one of the areas you want to focus on, is just even having a connection with a pediatric expert. That might be a place to start. Keep in mind, when we do these assessments, the data takes a while to come back. And so we really won't know what is happening probably for the next 4 to 5 years in collecting the data. The data for the assessment is going to be measured in quartiles. And so there's not going to be a specific percentage to say that you are pediatric ready. There's going to be a specific quartile that you may fit in that will tell you how ready you are. Also, keep in mind, when you do this assessment, your EMS agency, let's say your rural EMS agency B, you're not going to be compared to urban rural EMS agency C. You're going to be compared to a compatible EMS agency with similar population features and resources. And again, this is all for us to provide better pediatric care for our pediatric patients. And that's kind of how we should look at it. It's kind of a way to set the bar to where we are currently and figure out where do we need to go next.
Great. Well, thank you both so much. One, for all you do for pediatric patients, your passion for improving and for taking the time to go through this checklist. I know that I have found it really helpful as we embark on a region to go through this process and identify our opportunities. And I hope that others find it useful as well.
Thank you for having us.
Yeah, thanks a lot. Appreciate it.